Welcome, everyone. In today's Explainer, we're diving into literally one of the most high-stakes, life-or-death challenges in all of modern medicine. You know, revolutionary cancer therapies like CAR T-cells, they are absolute game-changers, saving lives right and left. But they can also trigger a terrifying biological response inside the patient. So today, we're looking closely at how critical care teams manage a grade 4 systemic inflammatory response syndrome. We'll be comparing two incredibly powerful weapons, Tocilizumab and Corticosteroids. Let's get into it.
Here's our roadmap for today. We're going to break this all down into 6 clear parts. First, the cytokine storm problem. Then, inside a grade 4 crisis. Number 3, targeted cytokine control. 4, broad immune suppression. 5, clinical decision-making. And finally, balancing risks and rewards.
All right, let's start with section 1, the cytokine storm problem.
So what exactly is SIRS in the world of oncology? Well, it stands for Systemic Inflammatory Response Syndrome. In the context of cancer treatments, specifically right after immunotherapies and CAR T-cell therapy, SIRS is basically this massive, uncontrolled systemic inflammatory response. It's wild because the very therapies we designed to hunt down and destroy cancer cells can inadvertently unleash an absolute storm within the patient's own immune system.
Down at the invisible cellular level, your healthy, normal baseline sits in really stark contrast to what actually happens during cytokine release syndrome, or CRS. Basically, these engineered T-cells interact with the tumor cells and just trigger a massive avalanche of inflammatory mediators. We're talking about a literal flood of cytokines, things like IL-6, TNF-α, and IL-1. And this overwhelming chemical release, it causes severe endothelial activation. Your blood vessels essentially become leaky, which we call capillary leak, and that leads to rapid edema, profound hypertension, and eventually organ failure. It's essentially a massive, destructive chain reaction going off right inside the bloodstream.
Okay, section 2, inside a grade 4 crisis. Now, we have to understand that a grade 4 SIRS event isn't just a mild fever or some minor allergic reaction. No, it is a terrifying, deadly medical emergency. When a patient hits grade 4, they are actively crashing. The storm has completely overpowered their body's ability to compensate, requiring immediate, aggressive, all-hands-on-deck intervention in the intensive care unit.
The defining features of a grade 4 crisis are absolutely critical to recognize. First, we see severe hypotension, and I don't just mean low blood pressure. This is hypotension that absolutely requires vasopressors just to keep blood flowing to vital organs. Add to that severe hypoxia and rapidly progressing multi-organ dysfunction. It's a truly deadly combination that demands an immediate, highly coordinated ICU response to literally pull the patient back from the brink.
Moving on to section 3, targeted cytokine control.
When it comes to treating this, clinical guidelines are crystal clear. Tocilizumab is the preferred first-line therapy for targeted cytokine control. In the incredibly high-stakes environment of an ICU, when you desperately need to shut down a cytokine storm fast, Tocilizumab is your absolute first-line defense. It really is the elite gold standard for managing cytokine release syndrome.
If we look at the exact pharmacology, you can kind of think of Tocilizumab as a highly trained targeted sniper. It's a monoclonal antibody engineered to do one very specific job. It binds directly to the IL-6 receptors, and by blocking those receptors, it halts that dangerous signal transmission dead in its tracks. The beauty of it is that it doesn't wipe out the entire immune system. It just surgically takes out the primary driver of the inflammatory storm, completely calming the cascade.
Which brings us to section 4, broad immune suppression.
But what happens when our targeted sniper just isn't enough to stop the storm? Well, enter corticosteroids. If tocilizumab is a sniper, corticosteroids, drugs like dexamethasone and methylprednisolone, are basically a broad, heavy shield. They step in and prevent immune activation right at the cellular and gene level. They don't just target one single receptor. Instead, they inhibit the production of multiple cytokines across a whole bunch of different inflammatory pathways. So it's a massive, sweeping suppression of the entire immune response.
And this brings us to the core clinical trade-off. On one hand, you have Tocilizumab. It gives you targeted IL-6 blockade, offering rapid cytokine control with way less global immunosuppression. But on the other hand, you have corticosteroids. These offer broad anti-inflammatory action, sure, but with a much slower onset and a significantly higher risk of global immunosuppression. Essentially, you're trading surgical precision for blunt force effectiveness.
All right, section 5, clinical decision-making.
So how do doctors choose? Well, it all builds into a very precise clinical algorithm.
Step 1 is always to administer first-line tocilizumab. You really want that rapid, targeted control right out of the gate. Step 2, if the patient is refractory, meaning, they just aren't responding to that first-line therapy, that's when you add the steroids. And then step 3 is the critical escalation. For those severe grade 4 cases, you do not wait. You combine both therapies immediately to hit the storm with both the targeted sniper and the broad shield at the exact same time.
There's actually a dedicated clinical playbook that guides doctors through all these high-pressure decisions. It carefully maps out what to do with progressive CRS even when first-line therapies fail. It tells them exactly when to consider higher dosing of steroids, when to evaluate for any concurrent infections, and exactly how to optimize supportive care. It's incredibly valuable because it takes all the guesswork out of what is a really chaotic medical emergency.
Finally, Section 6, Balancing Risks and Rewards. Now, as you can imagine, wielding tools this powerful comes with some pretty significant dangers. You can't just shut down a patient's immune system without facing consequences. This level of medical intervention requires constant, hypervigilant monitoring. By suppressing the immune system like this, we are massively increasing the patient's risk of infection. On top of that, clinicians have to closely monitor liver function tests, or LFTs, because of the tocilizumab, and aggressively track glucose levels, which can dangerously spike thanks to the corticosteroids. It is this constant, delicate balance between efficacy and safety.
Which leaves us with this final, incredibly critical question for the future of oncology. How do we balance the incredible, truly unprecedented cancer-killing efficacy of modern immunotherapy with the life-threatening biological storms they can unleash? For now, tocilizumab and corticosteroids form the backbone of our management strategy, allowing us to walk this extremely delicate tightrope. But as our treatments continue to evolve, so too must our absolute mastery of the human immune system. Thanks so much for joining me for this explainer. I really hope this helps you grasp the fascinating tightrope walk of modern medicine.